So let me discuss the treatment of chronic obstructive pulmonary disease. So the treatment of COPD, like we have the non-pharmacological treatment, that is non-pharmacological therapy, and as well as the pharmacological therapy. And apart from that, we also have surgical resections or surgical treatment as well. So I'll discuss all of them. So you take the non-pharmacological therapy first. Non-pharmacological therapy, it includes smoking cessation. Right, so stoppage of smoking. See, the single most important intervention in smokers with COPD is to encourage the smoking cessation, right? And as well as the behavioral approaches ranging from clinician advice to intensive group programs may improve the cessation rates. So if you just ask the individual to stop smoking, the chance of you getting the benefit from the patient to stop smoking is just only 5%. So that is the reason why the individual has to undergo the behavioral approaches as well. And for stopping the smoking, we also have certain pharmacotherapy as well. What are these pharmacotherapy? See, we have nicotine replacements, right? Nicotine replacement therapy. Second, we have varenicline. Right, and third important, like what we have is bupropion. Okay, so these are the three modalities of the pharmacotherapy for cigarette smoking cessation. Now, out of which varenicline, this is considered as the drug of choice, right? Varenicline, this is considered as the drug of choice for nicotine dependence. Then what is varenicline first of all? Varenicline, it is a partial agonist of nicotine acetylcholine receptors, right? So this is a partial agonist for nicotinic acetylcholine receptors. So that is what is your varenicline. Then you take this nicotine replacement therapy. This nicotine replacement, right, you know, it is given in the form of the nicotine buccal spray, right, and this nicotine is also available in the form of the transdermal patch and the other form will be in the form of nicotine gums, right, and then we have lozenges, and next we have inhalers or the nasal spray. Okay, so these are the various ways by which the nicotine can be supplemented within the individual. Now, what will be the effective pharmacotherapy will be is the combined pharmacotherapy. What do you mean by this combined pharmacotherapy? Combined pharmacotherapy means you have to, right, combine pharmacotherapy. So combined pharmacotherapy means you have to combine two forms of nicotine replacement. See, these are all the various forms of the nicotine. So you have to combine two forms of nicotine replacement, or nicotine should be combined with the bupropion, right? Nicotine should be combined with bupropion. So this is what is called as the combined pharmacotherapy. This have been recommended. And this varenicline, let me tell you one important point. Even though it is considered as drug of choice for nicotine replacement or nicotine dependence, varenicline is effective, but the use is limited, right? But the use of this varenicline is limited. Why? Because of the concerns about neuropsychiatric side effects. Right? Varenicline, it is associated with neuropsychiatric side effects. Then followed by that, the oxygen therapy. See, oxygen therapy, that is supplemental oxygen. right? This supplemental oxygen should be given for patients with resting hypoxemia. Right, should be given in individuals with the resting hypoxemia. And how much should be that resting hypoxemia? That is, partial pressure of oxygen should be less than 56 millimeters of mercury. Right? So, in this scenario, you need to give the supplemental oxygen. Right? And supplemental oxygen is the only therapy with evidence of improvement in the natural history of the COPD. Right? So, this will improve natural history of COPD, right? That is what is the purpose of giving the oxygen therapy. Okay, and what are the other benefits of this oxygen therapy? Even the home oxygen therapy, it is very much useful in improving the long-term survival of the individual, right? It will increase the long-term survival in patients with COPD. Which one? The home oxygen. And this home oxygen will also reduce the hospitalization, which is very important for patients with the COPD. And this home oxygen, it will also improve the quality of life. Right? This will also improve the quality of life. So that is about the oxygen therapy. Next, the other very important point you should remember is that survival in hypoxemic patients with COPD treated. So, the survival in hypoxemic patients with COPD treated with supplemental oxygen therapy is directly proportional to the number of hours per day oxygen is being administered. Okay. So, the improvement in individual with COPD is directly proportional to the number of hours of oxygen which is being administered to the individual, right? So that is about the oxygen therapy. And this oxygen within the home, it is being administered by the nasal prongs, right? It is being administered by nasal prongs. So oxygen by nasal prongs must be given for at least 15 hours a day. Right, should be given at least 15 hours per day. Okay, so that is about the home oxygen therapy. Now, if you see the indication for the home oxygen, this is a very important multiple choice question. Partial pressure of oxygen should be less than 55 millimeters of mercury, and oxygen saturation should be less than 88% while awake, at rest, on room air. This is the indication for the home oxygen, right? This is a very, very important multiple choice question. So, we have discussed smoking cessation. Second is the oxygen supplementation, right? Which is a very important treatment strategy in COPD, that is oxygen therapy. And next important therapy is the bronchodilators. So, the bronchodilators mainly they are given through the inhaled route. Right, so we have to give inhaled bronchodilators. So the inhaled bronchodilators, let me tell you, they do not alter the lung function, right? They do not alter the inexorable decline in the lung function. So COPD, I said you, it is a progressive disorder and it is an irreversible disorder. So whenever you are giving these bronchodilators, they do not alter the decline in the lung function. What they will do, these inhaled bronchodilators, they will just only improve the symptoms of the individual, right? They will only improve the symptoms, right? And they will also improve the exercise tolerance within the individual, right? They will also improve the exercise tolerance within the individual, and they will also improve the overall health status of the individual. So that is about your inhaled bronchodilators, right? And the most commonly, right, the most commonly prescribed short-acting bronchodilators. Right, most commonly prescribed short-acting bronchodilators, they are SAMAs. Now, what do you understand by this word? SAMAs, it stands for short-acting muscarinic antagonists. And what is the example of this particular SAMAs? That includes ipratropium bromide. Right, that includes the ipratropium bromide. Then followed by that, we also have short-acting beta agonists. These are also the short-acting bronchodilators, and the examples include the albuterol. Right, and another very important example is metoprolol. So these are the short-acting beta agonists, right? And these are delivered by, right, these are delivered by meter dose inhaler, or they are delivered as an inhalational solution by the nebulizer. So this is how the short-acting bronchodilators are being administered. And among these, which is considered as the first line agent? This is a very important multiple choice question. Ipratropium bromide, this is considered as the first line agent. Right, this is considered as the first line agent. Why? Because of its longer duration of action and absence of the sympathomimetic side effects. Okay, so this is considered as first line because it has longer duration of action and second important is absence of sympathomimetic effects. Right, absence of sympathomimetic effects. That is what is the role of ipratropium bromide. That is the reason why it is considered as the first line agent. Okay, so this ipratropium bromide, it achieves a superior bronchodilation in COPD patients than compared to that of the short-acting beta agonist. And if you take the dosage of the ipratropium bromide, this is given as 2 to 4 puffs. Right, this is given as 2 to 4 puffs, and that is around 36 to 72 micrograms, and this has to be given every 6 hours. Right, this has to be given every 6 hours. So that is about your ipratropium bromide. So these are the short-acting bronchodilators, that is short-acting muscarinic antagonist and short-acting beta agonist. Then followed by that, we have the long-acting bronchodilators. See, long-acting bronchodilators also we have long-acting muscarinic antagonists and long-acting beta agonists. Now, examples of long-acting muscarinic antagonists, that includes thiotropium bromide, right, and the second one is aclidinium, and third is umeclidinium. Right, so these are long-acting muscarinic antagonists, whereas long-acting beta agonist, that includes formoterol, right, and second we have salmeterol, and the third one is indacaterol. So these are the long-acting beta agonists, right? And we also have vilanterol. This is a new drug, right? So these long-acting bronchodilators, they appear to achieve bronchodilation that is equivalent or superior to what is experienced with the ipratropium bromide. Ipratropium bromide is a short-acting muscarinic antagonist, but whereas these, they are long-acting muscarinic antagonists and they have the superior efficacy than compared to that of your ipratropium bromide, right? Now, so these are about your bronchodilators. So if the question is seen like this, the initial drug of choice for patients with mild disease and no exacerbation, then the answer will be long-acting muscarinic antagonist. And what will be the example of those? That includes your thiotropium bromide, aclidinium, and then umeclidinium. And if you see the next question, if the patient has more severe dyspnea and airflow obstruction is present, then the drug of choice will be either LAMA, that is long-acting muscarinic antagonist, or LABA, that is long-acting beta agonist. Either of these can be initiated in those individuals with more severe dyspnea and airflow obstruction. So after having discussed about the bronchodilators, right, let me take up the discussion on the corticosteroids. See, multiple large clinical trials have reported a reduction in the frequency of COPD exacerbation with this corticosteroids. So the use of the corticosteroids is that there will be reduction in the frequency of the COPD exacerbations. Okay, that is what is the role of your corticosteroids, right? And an increase in self-reported functional status in COPD patients treated with inhaled corticosteroids have been shown in this clinical trials. So it will also improve the functional status of the individual, right? The corticosteroids will also improve the functional status of the individual, right? And these same trials, they have demonstrated no effect of the inhaled corticosteroids on mortality of the individual. So these drugs, there is no improvement in mortality. Okay, what they will do, they will reduce the frequency of COPD exacerbations, but no effect of the inhaled corticosteroids on mortality, or there is no effect on the characteristic decline in the lung function. Okay, so corticosteroids, what they are given through inhaled route, right? They are given through inhaled route. And inhaled corticosteroids alone should not be considered as the first line therapy in stable COPD patients. So these inhaled steroids, they have to be given along with inhaled bronchodilators, right? Inhaled bronchodilators. So this combination is found to be effective in the stable COPD patients. Okay, and these steroids, that is inhaled steroids, they have to be combined with the bronchodilators. And which particular bronchodilators? That will be your LABA, that is long-acting beta agonist. And when you combine this, this has been found to reduce the frequency of, right, this has been found to reduce the frequency of the exacerbations. Okay, so that is about the role of the corticosteroids. And let me tell you, when can you stop these inhaled corticosteroids? See, withdrawal of inhaled corticosteroids should be considered when patient have been stable for 2 years. So when can you stop the steroids? When the patient is stable for at least 2 years, then you can withdraw this inhaled steroids. Then, having discussed about the corticosteroids, the next important group of drug is the theophylline, which is a phosphodiesterase inhibitor. So this theophylline, it is given through oral route, right? And when will you give theophylline in COPD patients? It has to be given in those COPD patients who do not achieve adequate symptom control with anticholinergic drug. Okay, so if there is no adequate symptom control with anticholinergic drugs, right? Or there is no adequate symptom control with your beta 2 agonists and or adequate symptom control with steroids. That is the point when you need to add this theophylline. So what this theophylline will do? Theophylline will reduce the dyspnea, right? Theophylline will reduce the dyspnea and it will also improve the exercise performance. Right? This will also improve the exercise performance of the individual, and not only that, it will also improve the pulmonary function of the individual. Right? It will also improve the pulmonary function in many patients with stable COPD. Right? Now, in what way this particular theophylline will reduce the dyspnea? Let me tell you, this theophylline benefits from the bronchodilatation. So theophylline will cause bronchodilatation. Theophylline has the anti-inflammatory effect. Right? It has the anti-inflammatory effect or anti-inflammatory property, and it also has extrapulmonary effects on the diaphragm strength. Right? It will also improve the strength of the diaphragm, and it will also improve the myocardial contractility. So these are all the various effects of the theophylline, right? So this theophylline, what it will do in COPD patients, it will reduce the dyspnea, it will improve the exercise performance, and it will improve the pulmonary function in patients with stable COPD. Right? But the problem with the theophylline is that theophylline toxicity is a significant concern in the individual. Now, why is that you have to think of the theophylline toxicity? See, theophylline toxicity is a significant concern due to a narrow therapeutic index with this theophylline. So, theophylline, it has right, it has a narrow therapeutic index. Okay, so due to the narrow therapeutic index and long-term administration requires careful monitoring of the serum levels. And even according to your GOLD guidelines, right, that is Global Initiative for Obstructive Lung Disease guidelines, they recommend theophylline only as a last resort. Right, they recommend theophylline only as a last resort. If other bronchodilators are unavailable or unaffordable, then we give this particular theophylline. Okay. Next, we have another important group of drug, that is a phosphodiesterase 4 inhibitor, that will be your roflumilast. So roflumilast has been shown to reduce the exacerbation frequency. Right, has been shown to reduce the exacerbation frequency in patients who have moderate or severe COPD, that is either in chronic bronchitis or in patients with the emphysema. So that is about your roflumilast, which will reduce the exacerbation frequency, right? This roflumilast, it has to be combined with either LABA or LAMA, that is long-acting muscarinic antagonist, right? Or it can be given along with inhaled corticosteroid. So this is a very important multiple choice question, which is that phosphodiesterase 4 inhibitor, that will be your roflumilast. Now, What are the other measures that you have to take, particularly in chronic bronchitis patient? See, in chronic bronchitis patient, you have the presence of mucoid expectoration in the respiratory tree. Right, you have the mucoid expectoration in the respiratory tree, and this mucoid expectoration, right, this mucoid expectoration will increase, this mucoid expectoration will irritate the respiratory tree and will increase the cough within the individual with the chronic bronchitis. So what you have to do is, you have to increase the mobilization, right, you have to increase the mobilization of the secretions, right, you have to increase the mobilization of the secretions. And how can you increase the mobilization of the secretions? That is via adequate systemic hydration, right, that is via adequate systemic hydration and effective cough training methods, right, effective cough training methods, or the use of handheld flutter devices, right, and postural drainage, and sometimes with chest percussion, right, sometimes with chest percussion or vibration. By doing so, you can increase the mobilization of the secretions within the respiratory tree, right, and this postural drainage and as well as the chest percussion should be used only in selected patients with excessive amount of the retained secretions. So wherever there is excessive amount of, wherever there is excessive amount of retained secretions that cannot be cleared by coughing, that cannot be cleared by other methods, in them you need to do the postural drainage and the chest percussion or vibration you have to do in order to see that the secretions are being mobilized. And the other important treatment therapy is expectorant mucolytic therapy. See, this expectorant mucolytic therapy has generally been regarded as unhelpful in patients with chronic bronchitis, right? Cough suppressants, sedatives, they should be avoided, right? They should be avoided. And you take this opioid, that is morphine. Morphine can reduce the chronic dyspnea in patients with very severe COPD. Okay, so this expectorant mucolytic therapy has generally been regarded as unhelpful, right, in patients with chronic bronchitis, right, and you can give morphine. So if you give this morphine, morphine can reduce the chronic dyspnea. Right, morphine can reduce the chronic dyspnea in patients with very severe COPD. So that is about the role of your expectorant mucolytic therapy. Then you take the supplementation of the alpha-1 antitrypsin. See, among the etiologies when we were discussing, one of the very important etiology which is responsible for the development of COPD is alpha-1 antitrypsin deficiency. Right, alpha-1 antitrypsin, it is an antiprotease which will digest the protease enzyme which is being released by the leukocytes. So, in those individuals who have alpha-1 antitrypsin deficiency, you need to supplement this human alpha-1 antitrypsin. So, this is available, right? This is available for replacement therapy in emphysema. Right, this is available as the replacement therapy in patients with the emphysema. And this alpha-1 antitrypsin deficiency, it is a congenital deficiency, and that is due to SERPINA1 gene mutation. Right, that is due to SERPINA1 gene mutation. Okay, and in which group of individuals we give this alpha-1 antitrypsin? Patients over 18 years of age with airflow obstruction by spirometry. So, age group should be around 18 years of age with airflow obstruction. Right, with airflow obstruction by spirometry. Okay, and the serum levels of the alpha-1 antitrypsin should be less than 11 millimoles per liter. Right, should be less than 11 millimoles per liter. These are the potential candidates for the replacement therapy. And this alpha-1 antitrypsin, it is administered through the intravenous route, and the dosage is around 60 milligrams per kg body weight. Right, the dosage is around 60 milligrams per kg body weight once week. Okay, so that is about the human alpha-1 antitrypsin supplementation. Then followed by that, the indication of the antibiotics. Antibiotics are commonly prescribed to outpatients with COPD for the following indications. Right, number 1, to treat the acute exacerbations. So, acute exacerbation of COPD, right, that is one of the indication for the antibiotic treatment. Next, to treat acute bronchitis. Right, to treat acute bronchitis. And number 3, to prevent acute exacerbation of the chronic bronchitis. So, as a prophylaxis also, right, as a prophylaxis also, we give this antibiotic therapy. Then, what are those oral antibiotics? Because outpatient means definitely you give that oral antibiotics. So, what are those oral antibiotic formulations that can be given? Doxycycline 100 milligrams every 12th hourly, or trimethoprim sulfamethoxazole 160 bar 800 milligrams every 12th hourly, or cephalosporins, that is cefpodoxamine 200 milligrams every 12th hourly, or cefprozil 500 milligrams every 12 hours. Then we have a macrolide, that is azithromycin 500 milligrams followed by 250 milligrams daily for 5 days. Then a fluoroquinolone, that is ciprofloxacin 500 milligrams every 12th hourly. Amoxicillin clavulinate 875 bar 125 milligrams every 12th hourly. So these are the various oral antibiotic options that can be given in the following scenarios. What are those scenarios? Wherever mainly to treat the acute exacerbations, to treat the acute bronchitis, and prophylactically we give these particular formulations. Then, after having discussed about the medical management in patients with COPD, let me discuss the procedures for COPD. So, if you see the procedures for COPD, one of the very important procedure is the lung transplantation. Now, what are the requirements for lung transplantation? See, the requirements for lung transplantation or indications for lung transplantation includes whenever or the scenario reaches to an exhaustion of the medical therapy. So, the individual is refractory to medical management. Right, refractory to medical management, then you have to do the lung transplantation. right? And if the individual is having severe lung disease, which is limiting the activities of the daily living, right? Severe lung disease, which is limiting the daily activities of the individual. That is also an indication for the lung transplantation, right? And after doing the lung transplantation, the 2-year survival rate, right? The 2-year survival rate after lung transplantation for COPD patients, it is 75%, right? 2-year survival rate after lung transplantation for COPD patient is 75%. Now, what are the complications of the lung transplantation? So, the complications, right, that can be encountered include the acute rejection, right? Number 2, opportunistic infections, right? Number 3, obliterative bronchiolitis, right? Obliterative bronchiolitis. So, these are the complications that can be encountered in the COPD patients who have undergone the lung transplantation. Then followed by that, the another important procedure is the lung volume reduction surgery. Lung volume reduction surgery or reduction pneumoplasty, right, or reduction pneumoplasty. So these procedures, lung volume reduction surgery or reduction pneumoplasty, is a surgical approach to relieve the dyspnea and improve the exercise tolerance, right? So this will improve the dyspnea and it also improves exercise tolerance within the individual, right? It also improves the exercise tolerance within the patients. So particularly this lung volume reduction surgery, it should be done in patients with advanced diffuse emphysema and lung hyperinflation, right? Diffuse emphysema, right? And that too, an advanced diffuse emphysema and lung hyperinflation. In those scenarios, we do this particular lung volume reduction surgery, right? And bilateral resection, right? Bilateral resection of 20 to 30% of lung volume in selected patients results in modest improvement in the lung function or the pulmonary function. So bilateral resections, right, of 20 to 30% of lung volume in selected patients results in modest improvement in the pulmonary function of the individual, right? So this will improve the pulmonary function. And second important, exercise performance, and as well as the dyspnea. So whenever you do a bilateral resection, right, this will be the advantage. And the duration of improvement as well as any mortality benefit, whatever it is, remains little uncertain. But this is one of the procedure, that is lung volume reduction surgery or reduction pneumoplasty. This will relieve the dyspnea and it will improve the exercise tolerance in patients with advanced diffuse emphysema and lung hyperinflation. Next, Now, if you take this lung volume reduction surgery or lung transplantation, it should meet the criteria of the BODE index. Right? It should meet the criteria of the BODE index. So, if the BODE index is 7 or higher, right? If the BODE index is 7 or higher, in those individuals, right, we do this lung volume reduction surgery or lung transplantation. And what does this BODE index stands for? B, that is low BMI. O, that is severe obstructive ventilatory defect. Obstructive ventilatory defect. D stands for severe dyspnea. And E stands for poor exercise tolerance on 6 minutes walk test. Right? Poor exercise tolerance on 6 minutes walk test. So this is what is called as the BODE index. So when BODE index is more than or equal to 7, then that is an indication for lung volume reduction surgery or lung transplantation. And if you take the various parameters, these are the various parameters, and accordingly the scoring is being given. Right? So this is the BODE index scoring to estimate the mortality within the individual. If the score is like 0 to 2, right, the chance of mortality at 12 months is like 2%, chance of mortality at 24 months is 6%, and chance of mortality at 52 months is 19%. So as the score is increased, the chance of mortality is also increased. Right? So that is about what is called as the BODE index scoring to estimate the mortality within the individual. Then another important procedure is the bullectomy. See, bullectomy is an older surgical procedure for palliation of dyspnea in patients with severe bullous emphysema. So in patients with severe bullous emphysema, in this group of individuals, bullectomy has to be done, and it is an older procedure and it is a palliation of the dyspnea. And this bullectomy is most commonly pursued when a single bulla occupies at least 30 to 50% of the hemithorax, right? So this bullectomy, it is most commonly done when the single bulla, right, if it occupies 30 to 50% of the hemithorax. Okay, so that is when you need to do the bullectomy. Now these are the procedures: lung volume reduction surgery, lung transplantation, and as well as the bullectomy. So this completes the discussion of the treatment of your COPD. Now what I will do, I will just summarize the entire COPD. But before summarizing the entire COPD, let me explain you about COPD exacerbation. So COPD exacerbation, the individual will have acute onset dyspnea because these COPD patients, they are prone for recurrent infections, and infection, it is one of the most common cause for COPD exacerbation. So if you take the causes of COPD exacerbation, that includes the infection, right? Infections, and these particular infections, they include bacterial infection and as well as the viral infection. So bacterial infection, if you see, that is Haemophilus influenza, then Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa, and Enterobacteriaceae. So these are the bacterial organisms which are responsible for your COPD exacerbations. And if you take the viral infections, these viral infections include rhinovirus, then influenza, right, coronavirus, then adenovirus, and respiratory syncytial virus. So these are the viral infectious organisms which are responsible for your COPD exacerbations. And non-infectious pathologies, they include environmental pollution. Now, how do you manage these patients with acute exacerbation of the COPD? First and foremost, very important, supplemental oxygen, right? Supplemental oxygen, which is titrated to maintain the saturation between, right, which is titrated to maintain the saturation between 90 and 94%, right, between 90 and 94%. And the partial pressure of oxygen, that has to be maintained between 60 and 70 millimeters of mercury. So the supplemental oxygen, it has to maintain this particular saturation, and this has to maintain the partial pressure of oxygen between 60 and 70 millimeters of mercury. That should be the target of your supplemental oxygen, whatever you are giving. And the second important thing is the bronchodilators. And the bronchodilators which are being given is your ipratropium bromide, that is short acting muscarinic antagonist. And this ipratropium bromide, it is given either by nebulizer, right, 500 micrograms by nebulizer, or this ipratropium bromide, it can be given by the meter dose inhaler as well. And if at all, if it is given through nebulizer or meter dose inhaler, it has to be given every 4 hours as needed. And along with this short acting muscarinic antagonist, you also need to add short acting beta 2 agonist, and that includes the albuterol, right, that includes albuterol. So second part of the treatment will be your bronchodilators. Next thing is steroids have to be added. And what is the dosage of the steroid that we add in COPD exacerbations? That is prednisolone, 0.5 milligrams per kg per day has to be given, right, that is 0.5 milligrams per kg per day, and this has to be given orally for 7 to 10 days, right, for 7 to 10 days, right. This is usually sufficient, right, this is usually sufficient for 7 to 10 days, and followed by that the remaining 5 days or 10 days you need to taper the dosage of the steroids. And because the most common cause for your COPD exacerbation is infection, you need to give broad spectrum antibiotics, right, you need to give broad spectrum antibiotics. And in selected cases you also need to do chest physiotherapy, right, in selected cases you also need to do chest physiotherapy. See, one of the very important bacterial organism responsible for COPD exacerbation is Pseudomonas. So the antibiotic selection should be done whether the individual has the risk factor for Pseudomonas or whether the individual has no risk factor for Pseudomonas. So for patients without risk factor for Pseudomonas, mainly you take in case of ventilator associated pneumonia. When the patient is on ventilator, there is increased risk of your nosocomial infection, that is ventilator associated pneumonia. Mainly the organism is Pseudomonas. So in patients without risk factors for Pseudomonas, the management options, it includes the fluoroquinolones, and the fluoroquinolone that can be given is levofloxacin 750 milligrams orally or intravenously can be given, or moxifloxacin 400 milligrams orally or intravenously every 24 hours, So apart from the fluoroquinolone, the other group of antibiotic that can be given is the third generation cephalosporins. Right, third generation cephalosporins. So this third generation cephalosporins include ceftriaxone 1 gram intravenously per day or cefotaxime 1 gram intravenously every 8th hourly should be given. See, either fluoroquinolone or third generation cephalosporin should be given for patients without risk factor for Pseudomonas. But in those individuals who has the risk factor for Pseudomonas, in those group of individuals, you need to give piperacillin plus tazobactam. Right, piperacillin plus tazobactam. So the dosage of this piperacillin tazobactam, it is around 4.5 grams and this has to be given every 6th hourly. Okay, so this has to be given in those individuals who are at risk of the Pseudomonas. And apart from this, the other drug that can be given is ceftazidime. So this ceftazidime, it should be given 1 gram intravenously every 8 hours. Or the other drug that can be given is cefepime. Right, this cefepime, the dosage is 1 gram intravenously 12th hourly. Okay, so that is about your cefepime. Or you can also give even the fluoroquinolone, that is levofloxacin. So these are the antibiotics that should be given in patients with risk factor for Pseudomonas. So having discussed about the acute exacerbation of COPD, now let me summarize the entire COPD. So mainly we have two subtypes. One is your emphysema and the other one is the chronic bronchitis. So patients with emphysema, they are considered as the pink puffers, and patients with chronic bronchitis, they are considered as the blue bloaters. So if you take history and physical examination, like how will you differentiate both of them? In patients with the emphysema, dyspnea will be the major complaint, and the cough, if at all it is present, cough is rare. Right, the cough, it is rare. Okay, and patients, they are usually thin with recent weight loss is very common, and these patients, they appear uncomfortable with evident use of accessory muscles of respiration. And if you auscultate the chest is quiet without adventitious sounds. That means even breath sounds are also reduced in patients with the emphysema. Whereas you take in chronic bronchitis, that is blue bloaters, major complaint is the chronic cough with expectoration. Right, chronic cough with expectoration, where you have the mucopurulent sputum. Right, and the age group at which you commonly see this is around, often presents in the late 30s and 40s, which one? The chronic bronchitis. But whereas the emphysema, it is after the age of the 50 years. And dyspnea, if at all it is present, it is usually mild in patients with the chronic bronchitis. And these patients with chronic bronchitis, they are frequently overweight and as well as the cynosed. And peripheral edema is common, that is because of the development of the cor pulmonale. And chest is not like silent like what we see in patients with emphysema. The chest is noisy with rhonchi. Right, chest is noisy with rhonchi being invariably present. So this is about the differences in the pink puffers and blue bloaters based on your history and physical examination. And laboratory results, if you observe, in patients with the emphysema, the hemoglobin is around 12 to 15 grams per deciliter, right? And partial pressure of oxygen, it is normal to slightly reduced, right? It is normal to slightly reduced, that is around 65 to 75 millimeters of mercury. And partial pressure of carbon dioxide, it is slightly reduced to 35 to 40 millimeters of mercury. And why is that due to? That is because of tachypnea. So whenever there is tachypnea, there will be carbon dioxide washout, and that will cause reduced partial pressure of the carbon dioxide. And even if you observe the chest X-ray, you will have the presence of the hyperinflation with flat diaphragm in patients with the emphysema, right? And you take in case of the chronic bronchitis, right? They have very severe hypoxia. which will stimulate the erythropoietin production, and due to which there is increased erythropoiesis. So the hemoglobin is around 15 to 18 grams per deciliter, and partial pressure of oxygen is around 45 to 60 millimeters of mercury, and carbon dioxide is elevated because the bronchi are constricted. So carbon dioxide washout does not occur. So carbon dioxide levels are elevated, and that will make the individual to develop what is called type 2 respiratory failure. And chest X-ray, if you see, it is considered as the dirty lungs. What do you understand by this word dirty lungs? The chest radiograph, it shows increased interstitial markings, right? Increased interstitial markings. And diaphragm, in case of emphysema, they are flattened. But in case of these blue bloaters, the diaphragm is not flattened. Okay. So these are the differences of the laboratory studies between the emphysema and as well as the chronic bronchitis. And you take the pulmonary function test. See, airflow obstruction is ubiquitous in patients with the emphysema, and even if you take the total lung capacity, it is increased, diffusion capacity of the lung for carbon monoxide is reduced, and static lung compliance is increased. So that is what you will observe in the pulmonary function test. And you take in patients with the chronic bronchitis, there also you have the airflow obstruction, and total lung capacity is generally normal, right? Whereas in emphysema, the total lung capacity is increased and diffusion capacity of the lung for carbon monoxide is reduced. That is not the same that you will have in chronic bronchitis. So total lung capacity is normal, and DLCO is also normal, right? And static lung compliance is normal. That is what you will have in the pulmonary function test. Then, if you take the special evaluations like the ventilation perfusion testing, there is increased ventilation to high ventilation perfusion areas, that is high dead space ventilation, right? So there is increased ventilation to high VQ areas, and in chronic bronchitis, increased perfusion to low VQ areas. And if you take the hemodynamics also, the cardiac output, it is normal to slightly low in patients with emphysema, whereas cardiac output is normal in patients with the chronic bronchitis. And the pulmonary artery pressures, they are elevated in patients with the chronic bronchitis. But whereas in emphysema, there is mild elevation of the pulmonary artery pressures, but there is marked elevation of pulmonary artery pressures in case of the chronic bronchitis. Okay. So, and next is the nocturnal ventilation. See, there is mild to moderate degree of oxygen desaturation in patients with the emphysema, right? They will definitely have the nocturnal oxygen desaturation, and this is not usually associated with the obstructive sleep apnea. But whereas nocturnal desaturation or nocturnal ventilation in chronic bronchitis, if you observe, there is severe oxygen desaturation, and frequently they are associated with this obstructive sleep apnea. So these are some of the differences between your chronic bronchitis, which is your blue bloaters, and emphysema, which is the pink puffers. Now, having discussed in detail about the topic of COPD, let me just complete this topic by solving some MCQs. So if you see this question, alpha-1 antitrypsin deficiency is associated with centriacinar emphysema, panacinar emphysema, irregular emphysema, and the compensatory emphysema. Okay, so alpha-1 antitrypsin deficiency is associated with the pan-acinar emphysema, right? And this centriacinar emphysema commonly seen in the smokers, right? Commonly seen in the smokers. And this centriacinar emphysema, it is the commonest form of, right? The commonest form of all the patterns of your emphysema, right? Now, you see the next question. Gold criteria for very severe COPD is defined as, right, FE1 by FVC less than 0.7, and you take the other side. FE1 less than 80% predicted, less than 70% predicted, less than 50% predicted, and less than 30% predicted. So the answer is D, right, where the FE1 is less than 30% predicted according to your gold criteria. So what is your gold criteria? That is Global Initiative for Obstructive Lung Disease, right? So in this, very severe COPD means the FEV1, it should be less than 30% predicted. Then, and whereas you take mild, moderate, severe and very severe, in mild, FEV1 is more than 80% predicted, Moderate, it is 50 to 80%, severe 30 to 50%, very severe less than 30% predicted. So that will be your mild, moderate, severe and very severe COPD according to your GOLD criteria. Next, you see the next question. Which is correct about the interstitial lung disease? Type 1, type 2, type 3, type 4 respiratory failure. Let me tell you, in interstitial lung disease, the oxygen levels, they are reduced because of the diffusion defect. And even the oxygen levels, they fall on 6 minutes walk test also. But carbon dioxide washout occurs, that is because of the hyperventilation. And due to which, there will be type 1 respiratory failure and respiratory alkalosis. So, they will have hypoxemia, right? And they will also have hypocarbia. And this hypocarbia is the one which is responsible for the development of the respiratory alkalosis. Next, the following CT chest shows the presence of the emphysema, artifact, silicosis, pneumo-ultra microscopic silicovolcanosis. So, what is that you are able to make out, right? You have the presence of the hyperinflated lung fields, right? And there is the air which is accumulated in these particular hyperinflated lung fields, and that is the reason why it is appearing dark. And where do you have this bilateral hyperinflated lung fields with the presence of the bulla? That is in patients with the emphysema. So this is a case of the emphysema. So what is your CT chest showing? The large bulla in bilateral lung fields, that is diagnostic of the patients with the emphysema. Next, increased read index is characteristically or classically associated with chronic bronchitis, bronchiectasis, emphysema, interstitial lung disease. So, increased read index is classically associated with the chronic bronchitis. So, what is this read index? Already we have discussed in the theory session. That is, read index, it is a ratio between the thickness of the submucosal secreting glands to that of thickness of the entire bronchial wall. That is what is called as the read index. And how much is the normal read index? The normal read index, it is around 0.4. Right? Normal read index, it is around 0.4. But in patients with the chronic bronchitis, if you see, the read index will be more than 0.5. Right? It will be more than 0.5. And that is very much indicative of your chronic bronchitis. Okay. So, read index will tell you what is the severity of chronic bronchitis. More severe is your read index, right? More severe will be your symptoms as well. Next, what are the drugs used for smoking cessation? Clonidine, bupropion, varenicline, all of the above. The answer here is the all of the above. But what is the drug of choice? Varenicline is considered as drug of choice for nicotine dependence. But it is of limited use. Why? Because of the neuropsychiatric adverse effects associated with the varenicline. And clonidine, it is actually an antihypertensive drug, but that is also given in the treatment of the smoking cessation as well. But this clonidine will be a second line therapy. And apart from clonidine, right, you take the other formulations, that is nortriptyline, which is a tricyclic antidepressant. But what are the first line therapies? The first line therapies include the nicotine replacement, and this nicotine replacement can be done in the form of gum, patch, nasal inhaler, oral inhaler or lozenges, right? And then we have varenicline and as well as the bupropion. Okay, so the one which is having the highest efficacy is varenicline and as well as nicotine nasal inhaler. So these are the one with highest efficacy, right? But the usage of varenicline is being limited because of the neuropsychiatric adverse effect. Next, in a patient with COPD with low partial pressure of oxygen at rest, best management option is, you see this question, best management option, quit smoking, bronchodilators, low flow oxygen, mucolytic. So with low partial pressure of oxygen at rest, the best management will be your low flow oxygen, right? And this low flow oxygen, it abolishes the constriction, leading to improvement in the ventilation perfusion mismatch. right, leading to improvement in the ventilation perfusion mismatch. And this will also abolish the bronchoconstriction. And the oxygen that you have to give is the low flow oxygen, right? You need to give the low flow oxygen, but when you are giving the high flow oxygen, right, so the high flow oxygen is not tolerated as it leads to crusting. So high flow oxygen will lead to the development of crusting, right, and there can be dryness of the mucosa, right, and there can be development of the epistaxis. So these are the disadvantages of the high flow oxygen, right, and the treatment is guided by the partial pressure of oxygen, which should be maintained at 60 millimeters of mercury, right. The treatment is guided by your partial pressure of oxygen that should be maintained at 60 millimeters of mercury. Okay, so that is about the story of your low flow oxygen, and high flow oxygen should be avoided. Okay, and what do you understand by this low flow oxygen? That should be given at a rate of 6 liters per minute, and gradually it has to be increased depending upon the individual response. While continuous therapy is required for patients who show hypoxemia at rest, in them you need to give the continuous therapy. In patients with smoking history, which is important? Duration of smoking, number of smoking, or brand of cigar, or filter of cigar? Let me tell you, it is the duration of smoking which is very important, right? So it is a highly debatable topic. Most search results and discussion have shown that it is the duration of smoking that is found to be more important than the number of cigars being smoked per day, right? Next, emphysema presents with all except cyanosis, barrel-shaped chest associated with smoking, type 1 respiratory failure. See, emphysema patients, they are considered as the pink puffers, right, and they don't have the cyanosis. Cyanosis, it is like your blue bloater seen in patients with the chronic bronchitis. So that is the reason why cyanosis is not the feature in patients with the emphysema. But barrel-shaped chest is seen. Associated with smoking is true. Type 1 respiratory failure is also true. Next, which component of cigarette smoke is responsible for the development of coronary artery disease? Nicotine, tar, polycyclic aromatic hydrocarbons, benzene. It is the benzene within the cigarette smoke that is responsible for the development of the coronary artery disease. Now let me tell you what are the toxic substances in the cigarette smoke and what is the effect on the body. So if you take the toxic substance in cigarette smoke, that is acetaldehyde or anabasine, that is the one which is responsible for addictive nature of the smoking. Then benzopyrene. Benzopyrene, it is carcinogenic, cardiotoxic, and reproductive potential toxicity is being present. Carbon monoxide in the cigarette smoke, it is responsible for reproductive potential toxicity. Vinyl chloride in cigarette smoke, it is the one which is responsible for the carcinogenicity. So these are some of the important multiple choice questions related to the topic of COPD. So with this, I'll wind up the session of COPD. Thank you very much.